Welcome to Relax and Listen, Improving Healthcare Experiences and Outcomes for Individuals with Substance Use Disorders. This talk has been brought to you by the Brattleboro Retreat and the Windham County Consortium for Substance Use, or COSU. Today you'll be hearing from Dr. Geoff Kane, an expert in addiction medicine. He's the Chief of Addiction Services at the Brattleboro Retreat, and is the founder of Meetinghouse Solutions, LLC, which promotes resilience and recovery at the community level. I've known Dr. Kane for over 15 years, and he's been a friend and mentor to me in a great many ways, and it's been a tremendous pleasure to see his thinking about addiction and substance use disorders grow and evolve and deepen over the years. He's been somebody who is consistently ahead of the curve on almost every important trend in the world of addiction medicine and co-occurring disorders treatment. And this talk is no exception. I hope that you will enjoy it as much as I have as he delves into complicated issues of how to reach and help the complicated individuals who come to our offices for help with substance use disorders.
Thanks, Kurt.
Relax and Listen, Improving Healthcare Experiences and Outcomes for Individuals with Substance Use Disorders. A topic relevant to healthcare providers, certainly, and healthcare exists in communities, and everyone in a community that's concerned about substance use disorders, be it the opioid crisis or continuing alcohol problems or whatever else, there's material here relevant for them too. So welcome. My medicine and social medicine training was in the Bronx at the Montefiore Medical Center. One of the appeals of training there was that my emergency room rotation and some of my medicine rotations were at the Morrisania City Hospital in the South Bronx. It's been closed for years, but it was a valuable part of the training for me. And after I gave a resident seminar on the medical management of alcohol withdrawal states, the medical director of the emergency room had me go there every month to the emergency room and recap that as a conversation with the interns and residents working there, sometimes medical students. I got a picture of the whole building, which is now an apartment building in the Bronx, but I couldn't get a picture of the entrance to the emergency room, which has special memories for me because I can recall helping a woman deliver a baby in the back seat of her Mustang right outside the emergency room. But I was coming out of one of those talks with the house staff and medical students, and the nurses looked over and saw me and said, "Well, here's Kane, he can deal with it." And they directed me to a gurney out in the hallway in the emergency room with a young woman lying there. And she had come in maybe an hour or two before that, intoxicated, and the ER staff hadn't really assessed her yet. So they were leaving that to me. So here I was. I happened to be trailed by 2 or 3 medical students, approached the gurney as this senior resident, very junior attending, whatever I was, not at all confident I was up to the task that they were laying on me. Walked over to the woman. I hope I introduced myself. I'm not even sure. But I asked a general open-ended question about what she was there and what was going on. I think in my heart, I was thinking, oh my goodness, lady, I hope you know what's going on and you'll tell me because I don't have a clue. And she sat up and immediately described what had happened that day. She had been in some sort of a domestic argument, not violence, but argument, and was very upset. There was alcohol there. She drank a lot and wound up so intoxicated she was brought to the emergency room. A few questions, it was clear she wasn't addicted to alcohol, was not at risk for withdrawal. She was not a regular drinker, and she had already metabolized enough of the alcohol that she was reasonably coherent. So I bid her farewell, told the nurses what was going on, to mobilize whatever social services we had in those days in the hospital to help her settle her situation down. As I think back on that, I didn't even debrief with the medical students. I was just glad to have gotten through the episode and moved on. So I wasn't at all relaxed. I did listen to the patient, and listening to patients is one of the major emphasis today. And important themes. Prior to my medical training in college, I was in freshman biology about 10 years after Watson and Crick described the structure of DNA. The biology teacher used to punctuate his lectures by saying, variation is the law of life. Once in a while it was in context, sometimes he'd just say it because it was such a scientific fact at that point that he wanted us to recognize. Variation is the underlying problem in a lot of the discord that exists in healthcare, especially healthcare around substance use disorders. And we want to talk about that and get more clear about the understanding of the biology and the what's going on in nature rather than our own conceptualizations, so that we want to improve our effectiveness by improving understanding. And that applies to healthcare, it applies in communities as well. One of the points of controversy is abstinence, and abstinence only as a means of dealing with substance use disorders versus harm reduction. And there are extreme views upholding one or the other as the only way. And the reality is that there are people who need more of one or more of the other. And when we become person-centered in our healthcare, we're better able to sort of tailor what we do to the individual rather than expecting the individual to tailor themselves to what our beliefs and recommendations are. And problems to person-centered, they move. People over time may have a different take on what's important for them and what their values are. The end game here, I think, is to have people using or not using substances responsible in a way that meets their own values. And it's important for us to respect autonomy as we're taking that into account, and to understand that there are aspects of each individual. I would put those under the heading of the fairly newly circulating term recovery capital, which means different things to different people. People go into different depths of that, but if you think of it as all the resources somebody brings to their life that has preventive value or protective value with respect to substance use disorders, it also has prognostic value. They're more likely to get better if they have more established mental and emotional maturity, higher education, job, stable home, social supports, than if they don't have those things. And in recovery, people build up those things, which is one of the things that is an incentive to continue in recovery. It's valuable to think ecologically, that is, to take into account the social, economic, cultural, structural problems that contribute to addiction, as well as what's going on in the individual. And all the more reason to for people in communities to be interested in this discussion, as well as healthcare providers. A final note here on mindfulness, being aware of what's going on in our lives in the present and being non-judgmental about that is valuable for us, healthcare providers, citizens, whatever. It's also valuable for the people we work with, because if we're non-judgmental towards them as well as ourselves, that helps them be who they are. And if if we pass along a taste for mindfulness practices, that helps them to be better in their own lives themselves. There's a lot of emotion connected with some of the things we're talking about, and this image of a Yankees cap and a Red Sox cap sort of captures. I'm here in Vermont, not too far from Boston, not too far from New York City. There are a lot of people who emotionally have positive reactions to one of these teams and negative reactions to the other, and that happens quick. It happens automatically, and to be aware of how bias can affect us is a valuable insight. Tamara Levitt, whether or not we realize it, we see all the world through a lens of biases and judgments. Not only that, if we regard an individual different from ourselves, there's often an automatic judgment and establishment of a pecking order. We may look down on the other. That's the process of othering, and attach a label to them that is disdainful. I mean, the two birds of different feathers are looking in opposite directions and typing one another with a label. And as human beings, we deal with variation by establishing categories. A category is a natural response to reality or variety in reality, and it facilitates thinking and communication. I can't imagine the National Football League having a draft without some categories like wide receiver, defensive tackle. The body types are different, the skill sets are different, yet within each category, there's also a lot of differences among the particular players. But wide receiver and defensive tackle are valid and useful categories in that draft process. These categories, so they're concepts, they're not things. Picture someone going into a furniture store and saying, I want to buy a chair. The salesperson's at a loss. Well, a dining room chair, a kitchen chair, a lounge chair. It has to be more specific to be translated into an actual thing. Labels are concepts. They also evoke judgments like the birds, hippie, goth. And when those judgments exist in our social environment, they can have an effect on us, our self-esteem, our coping capabilities, and our ability to adapt to whatever's going on in our lives. Especially, I think, if the judgment is applied to self. I encounter individuals in my work who might use the term, I usually don't use these terms at this point, but addict or alcoholic, and some may use the term with loving respect and acceptance, particularly if they've been in a recovery program where people are bonded and respectful to one another. There are other people who say those words with an edge to it. That's something they don't like or want about themselves and struggle against that. So self-judgment can be part of the problem that we can help people with when we approach them non-judgmentally. Labels categorize. I would invite you to think more descriptively. When we describe something, it's more individualized. The person who said, I have an unhealthy relationship with alcohol. I don't drink every day, but when I do drink, I drink an inappropriate amount. What more did I have to hear? What more did I have to know about that person? They didn't like that. It was inconsistent with how they wanted to live their lives. And abstinence from alcohol for that particular person made a lot of sense. And a treatment team could help them realize how to go about that. There's lots of respectful, helpful, caring, empathic connections that go on in healthcare these days and in communities. Unfortunately, there's also a lot of this Denmark drawing of colliding speech balloons. There's lots of expression, really no communication and no connection here. And the sort of understanding I hope that we can cultivate through this talk, through your own mindfulness work and whatever, will break down this tendency, because Madeline L'Engle, the more hotly they argue, the more widely they miss the point. The more this goes on, the less collaboration and communication. And interpersonal neurobiologists say we're hardwired to need one another. Well, if we need one another, we need to communicate with one another. Labels and categories increase communication, yet when there's bias and judgment attached to them, they can cause that sort of collision of speech balloons. And people are attached, for example, to thinking of addiction as a disease, and labels such as that can reduce shame, judgment, stereotyping, or othering, yet sometimes they increase it. And to be comfortable working kind of with specifics in the moment and not over valuing categories is an important approach. Labels can increase or decrease hope and self-acceptance, motivation. Some people are drawn to help people because of their characteristics, and some people are repelled. So it can increase or decrease support. The availability of healthcare benefits, resources, medications. For many years, there was not parity in healthcare in terms of benefits for the treatment of substance use disorders. That's gotten better, although there still seems to be some hurdles that people face that they wouldn't face if they had a different sort of illness. Whether individuals take responsibility and pursue recovery can be increased or decreased by labels. Some individuals, the label becomes part of their self-justification, or some people live their labels. A psychiatric patient may say, well, I had problem with my bipolar, and that led to the impulsivity and consequence. Bipolar being a diagnosis, it's not a thing that exists outside the patient that shoves them one way or the other. It's a convenient way of identifying people who have enough in common that they respond to common treatments. But some people live their labels. If I meet a patient who introduces themselves as, well, I'm a chronic relapser, I try not to interrupt, but I may gently get in the conversation right there and say, wait a minute, you may want to not use language like that, because that's language that predicts the future as well as describes the past. Maybe make a historical statement. I've had a lot of relapses, but resist predicting more of the same. Tae-Yoon Kim, if you give equal time to images contrary to your objective, it would be like trying to dig a hole and fill it in at the same time. People will struggle against, I don't want to be this, I don't want to be that, and give energy to the negative. It's similar to instructors who are helping skiers learn to ski with trees or ride mountain bikes among the rocks. Look where you want to go. Don't look at the tree. Don't look at the rock. If you look at it, they call that targeting. You're more likely to hit it. Now, even as we're helping people to be careful with their language, Leston Havens, above all, the clinician must not shake what little faith the patient has in himself. if a patient is starting to come to terms with addiction and they say, well, I can do this, I have a lot of willpower, the next thing out of my mouth is not to tell them about the addiction psychologist years ago who wrote a book titled Willpower is Not Enough. I may want to encourage them to apply that willpower to staying away from the situations that might get them back in trouble. But I don't want to like contradict the patient's perception of their asset. William Osler, listen to your patient. He is telling you the diagnosis. In my woman on the gurney at Morrisania story, I listened to the patient. I think I wish I had this Osler quote in mind at the time. I might have had more confidence as I went about doing that. Dos animata. Through judging, we separate. Through understanding, we grow. And when there are differences, if we hang out with birds of a similar feather and that's satisfying, that's okay. When birds of a different feather come along, it helps to be curious and to learn more about them rather than to dismiss them, rather than to other them. Tamara Levitt tells the story of she was traveling, she was on a long taxi ride, she struck up a conversation with the taxi driver, and within a minute or two, it was clear they had very opposite views on politics. It was a long taxi ride. She decided not to go into that discussion, but she was curious about other things. She learned that the taxi driver came from a country in Africa where in 1984, he had been on the Olympic track and field team. And now in the community where he lived, he was mentoring and helping coach high school students in track and field. She wound up learning something about him that clearly resonated with her own values and turned the experience into a positive one. Now, let's move into substance use. In communities, there are a lot of representations of the range of involvement or difficulty with one or another substances. This particular triangle is related to alcohol and drinking. Sometimes it's a pyramid, sometimes it's a triangle, sometimes it's lying on its side, but you get the idea. This represents the range of use within a community. At the bottom of the pyramid, where maybe a lot of the people are, there's rare use of alcohol or total abstinence. In some surveys, a third of people don't drink at all. People who drink a lot have trouble believing that, but a lot of people just don't drink for whatever reason. As you go sort of toward the point of the pyramid, the severity of problems starts to get into people with mild or moderate substance alcohol use disorder. The top of the pyramid is those individuals with addiction. And a lot of my thinking as a physician, I've worked in hospital settings for like 25 plus years where there was a lot of withdrawal management and as much rehabilitation as we had time with the patient. So a lot of my clinical learning, I like the saying, I think from Estonia, the work will teach you how to do it. A lot of what I learned from the thousands of patients I encountered in those settings was about how to recover and cope with serious addiction. I was aware of people in the community. Now, in the last 5 or 6 years, I've worked more in outpatient settings, and I'm meeting more of the people who are not in that dependence category and who have more options about what they might want to do or change or not do or change. The people that I have met in serious addiction treatment, I describe as at the deep end of the pool of their substance use disorder. This is a real subset of the population of people who use substances. And in this schematic of a swimming pool, there's a person struggling at the deep end of the pool. There's also some poor chap on the bottom of the pool. And some people in recovery will say, I had to make some changes. The only option for me was jail, institutionalization, or death. And that has been a reality for a lot of people. And if they don't embrace lifestyle changes and ongoing ways of growth, then they may sink. And so I want to start off talking about what I've called a classic genre of addiction. Genre and classic may be redundant, but I wanted to emphasize the point that even within this group of people at the tip of the triangle, there are a lot of differences. Genre. Romantic comedy is a genre of motion pictures, I think of Sleepless in Seattle, You've Got Mail, both starring Meg Ryan, Tom Hanks, both co-written or written and directed by Nora Ephron. They have romance, humor, suspense, yet they're totally different motion pictures. You can't exchange one script for the other or one line for the other. And so too with addiction. The thousands of people I met in the intensive care unit for addiction all had different stories, yet there were some things in common. On the self-perceived side, the perception side, the subjective side, powerlessness. Now, that's a word that's been in play since the 30s with 12-step programs. It has been difficult for some people, particularly women or people who have been disadvantaged and they've been struggling to find their own voice and effectiveness in their lives, to identify themselves as powerless. The way I think of powerlessness, it's very specific to what let's call a disconnect between intention and behavior. And we'll talk about how that comes about. But people will not be able to control their behavior as well as they might ordinarily. I can decide to wave my hand, which is voluntary. Earlier, because I was nervous about talking with you, my hands were shaking a little bit. I couldn't control that. And that disconnect between intention and behavior is what this powerlessness thing is all about, the way I think about it. On the objective side, the outside person looking at someone with an addictive illness, there's persistent use of this substance despite all kinds of adverse consequences, trouble in health, relationships, citizenship. One way of describing that, rather than, we'll use the label of classic genre or an addiction, but one way of describing that is the individual's relationship with a particular substance or substances displaces valued relationships with themselves. They're not looking after their own well-being and health. Others, they may be misleading people, appropriating property from people to do things, and they're not even respectful of the universe. Years ago, I was touring a single occupancy hotel in Harlem with a big, strong substance abuse counselor who said to me, Geoff, if it weren't for alcohol, this elevator would not smell like a urinal. So how do people get in this kind of a fix? All addictive substances, by different pathways and mechanisms, produce a surge or spike of dopamine in the nucleus accumbens, which feels good, maybe 6 times the pleasure of food or sex, or 5 times the pleasure of food or sex. And some people like that, they go back for that. It's their use is reinforced. They go back for more pleasure. Other people, especially individuals who have been traumatized, and there's a lot of that underlying addiction with substance use disorders, they get relief from displeasure, from unpleasant memories and feelings, and psychologists would call the pleasure a positive reinforcement, the relief from displeasure a negative reinforcement, and this has the effect of training, conditioning, reinforcing automatic behaviors to obtain and consume substances. So it takes place at primitive emotional levels, brainstem, limbic system. It's closely analogous to the muscle memory of athletes who they want to be in the zone. They don't want to be thinking too much about their moves so that they'll do it more smoothly and effectively. Now, once this behavior gets conditioned, it may be consciously influenced, but not reliably consciously controlled. And that's the disconnect that I mentioned between intention and behavior. Not reliably consciously controlled. And just to stay with that thought for a moment, picture sitting at a dinner table, deciding not to have a second helping or deciding not to have dessert. You reach out and take it. Or perhaps flirting with someone before you even realize that you're attracted to someone. Those would be examples of automatic behaviors originating from this primitive emotional level. Now, not only is the plight of the person with classic genre addiction prone to these behaviors without kind of deciding to, what they decide in active addiction is disordered also. Addiction psychologists or neuropsychologists use the word salient. What's salient, what's important in the moment is often more substance rather than self-preservation. So there are moments when there is no choice. The addictive behaviors might be triggered by withdrawal or the anticipation of withdrawal. Very powerful. By having just one of whatever the substance is. And habits, rituals, people, places, things. Stress or other unpleasantness sometimes will evoke the addictive behaviors. Even feeling good has been said to be the fourth leading cause of reinstatement of use after people have been abstinent for a while. I would emphasize the just one characteristic. One individual said, well, I thought I could have just one. And I said, have you had that thought before? He said, yeah. I said, well, how many times? And he said, well, maybe 30. Made the mistake over and over again. I identify myself as genetically engineered to like alcohol too much. There's a big family history. Have not used alcohol, beverage alcohol, since like 1989, years and years ago. I was not in the deep end of the pool of alcohol use disorder. I may well have been in the shallow end and kind of get out of the pool by just not drinking at all. I'm okay with that. The just one. With COVID, one of the changes in my life, I started making cookies. And I was making cookies one day and opened the vanilla extract close to my nose. High proof alcohol content. I got one whiff of the vanilla extract and part of my brain lit up. It was, whoa, that's interesting. I recognized it, measured some out, and now I hold the bottle at arm's length if I'm doing that. But that sense that part of my brain lit up was consistent with the biology of the connection to that particular chemical substance. Individual with severe alcohol use disorder started using hand sanitizer with the pandemic that was produced by a local distillery. So it was ethyl alcohol. And after using that for a while, reinstituted use of beverage alcohol for a bit. And you know, that kind of sanitizer had to get thrown out. So the person in active addiction they'll take action without decision. Say I'm someone with severe alcohol use disorder. I decide I go into the sports bar to check the scores and see my friends. I'm planning to have a ginger ale, but my mouth says a shot and a beer, please, as soon as I get near the bartender. So there can be action without decision, or action despite decision to the contrary. I'm really going to have a ginger ale today, but my mouth still says a shot and a beer. Now, and as I said before, the conscious decision making with the salience of use, more substance becomes salient and nothing else matters. And that instinctive, primitive, involuntary drive can determine behavior. And I liken it to holding my breath as long as I can, and then I'm going to take a breath and nothing else matters. And that take a breath and nothing else matters is the plight of the individual with severe substance use disorder who's maybe in withdrawal or in intense craving. And that's the situation where there's that disconnect between intention and action. So they'll do things that put their own health and safety in danger, their own legal freedom in danger, put their own children in danger. And that can scare or offend the observer. But after I had described this, take a breath when I can't hold my breath any longer, to a group of new staff here at the Brattleboro retreat, a nurse said, "You really can't judge someone for breathing." In the thousands of stories that people shared with me in that like 25 years of inpatient work, after the first several years, it became clear that people interested in lasting recovery and abstinence seemed to be important if they were going to have lasting recovery. These individuals at the deep end of the pool. And I looked for ways to support them in making lifestyle changes. And the sort of two guidelines that distilled what these patients had taught me is because of this disconnect, the neurobiology of it, you can't trust yourself, so keep your distance. And you can't do it alone, so ask for help. Build the resilience that will help you to stay on this path that you've chosen through the nurturing and growth and increased maturity and responsibility that comes with positive interpersonal relationships. With some essays, I communicated those in a workbook, which is geared toward understanding and actions for people in the deep end of the pool. And there's a few workbook pages in the back that will help people to get specific about what they need to avoid and who they need to be talking with. I shared this with patients who are in established recovery, and they were annoyed because they didn't want to look at the workbook pages and go back and think about what they had left behind. And that's fair enough. But now, if we move from the classic genre to start to think about everybody else, we start to get into abstinence only and harm reduction. There are people in the deep end of the pool who have survived and thrived because they decided that for them a drug is a drug is a drug. They want to be abstinent from everything they can be abstinent from and proceed with that kind of recovery. And that's in this sort of abstinence only column. For a long time, that was kind of the only way people were thinking about addiction and recovery. And it was useful and necessary for some, people from the deep end of the pool. There are other people who it may be unrealistic for. And that led to harm reduction entering into the treatment of substance use disorders. Harm reduction kind of got started with the HIV epidemic and the realization that not only were men who have sex with men at risk, but intravenous substance users who shared injection equipment, needles, could become infected. So concerned people, including professionals, would say, well, no, okay, if you're going to inject, at least use clean needles, and here's some alcohol swabs to go with them. It was caring, it advocated safety, respect, and respected autonomy. And for someone who wants nothing to do with abstinence only. It's a way of helping to reduce the harm to them and keep them safe. The need for avoiding extremes comes that some individuals, for their own safety and survival, need to remain abstinent. Other individuals who want no part of that have this harm reduction option, which is at least safer. There's still risks involved, but the risk tolerance of the individual is part of, or our respecting that is part of respecting autonomy. At the beginning of a book on harm reduction psychotherapy, Alan Marlatt, a famous psychologist, says, "Would I recommend a non-abstinence goal for someone with severe addiction problems?" He puts the focus on the client. My response is to shift the issue of goal choice back to the client. I'm willing to work with clients, whatever their goal may be, from abstinence to moderation. Clients often change their goals as treatment progresses or fails to progress, from harm reduction to abstinence, or the other way around. Even if a client is not interested in moderation, I want to keep using as much heroin as I can get, harm reduction can improve their situation by, I see harm reduction not as saying it's okay to use, it's saying, well, if you want to use, I respect that choice, and we won't hassle you about your use. So back to that triangle, and there's more to substance use in our communities than what we see in intensive care. William White, in his compendium of the history of addiction and recovery in the United States, Slaying the Dragon, puts his authority behind it. Alcohol and other drug problems in the community, even problems that meet diagnostic criteria for substance use disorders, are generally less severe, less complex, and less prolonged than those problems found among people entering addiction treatment. And I'm saying that's what I've observed, having worked in the kind of, I call it the intensive care unit of addiction treatment, and also working in outpatient with people who haven't been there, don't have this classic genre, they have something else. There's increasing evidence to support what White is saying, what I'm saying. For example, Ann Fletcher has a book, Sober for Good. She didn't start looking in treatment centers. She started in the community and advertised for people who had problems and now don't, and had been successful for a long time, and sent them all questionnaires and analyzed the responses. And there were people who had done the conventional thing. They went to maybe through a withdrawal management program, went to a residential program, worked a 12-step program, and they were happily in their kind of recovery. There are also individuals who approached it differently without that conventional approach, and they were happy and thriving in their form of recovery. There's a lot of different pathways that we now have evidence about. We might have assumed that there are a lot of anecdotal information that young men who drink too much in their maybe late teens, early 20s would mature out of their substance use problem by age 30, perhaps as more responsibilities came their way, and anticipating the further discussion of recovery capital, more reasons not to drink came their way. John Kelly, addiction psychologist and founder of the Recovery Research Institute in Boston, and his group published results of a national survey. 40,000 people selected. About 2,000 of those said that they had a substance use problem and now they don't. And the survey is asked, how many serious attempts did it take to resolve that problem before you overcame it? The range was 0 to 100. There's a question that the people who said 0 misread the question, so they may have had one attempt, but even so, the range from 0 to 100. If I'm quoting this study to patients, I want to emphasize 0 to 100. Plenty of reason to have hope. What's this, the adage, if at first you don't succeed, try again. For example, there's good research data. There are good research data on nicotine dependence, that individuals who have made 7 or more serious quit attempts are overwhelmingly, in the majority, ex-smokers, former smokers. And the average number of serious attempts in this study was 5.35, but the statistical mode, the most common number, was just 2. Now, John Kelly likes to point out that this view of substance use disorders in the community doesn't mesh too well with the definition of substance use disorders or addiction as a chronically relapsing brain disease. And he doesn't like the expectation that description gives to people who are in the community. So here's a different picture of a swimming pool. There's somebody swimming in the deep end of the pool and somebody standing confidently in the shallow end of the pool. And they're not following the rules that people think, who sort of have a fixation with the classic genre. They're not following the rules of how this is supposed to work. And we need to get out of thinking about those rules and deal more with the people in the communities who have experiences like this. So the person swimming in the deep end of the pool could be one of those individuals who thinks of themselves, and other people think of them as perhaps a social drinker, yet maybe in their 60s or 70s develop alcoholic cirrhosis of the liver. The risk is there. And the person who's confidently in the shallow end of the pool may move a little bit deeper and find themselves in over their head. First time I used this diagram, I couldn't get a commercial artist to do it, so I drew it myself. I would have instructed the commercial artist to put a gently sloping floor to the swimming pool. My unconscious must have provided a view of how I view these things as pretty treacherous, because that's a sort of a wicked slope in that sketch. For more information about the person who's stroking away in the deep end of the pool, I would recommend Sarah Allen Benton's book, Understanding the High Functioning Alcoholic. So here's sort of what exists in communities. There are some people who use potentially legal or illegal substances without addiction or an identifiable substance use disorder. And I would emphasize, there are people who are relatively casual in their use of alcohol, or now the legal substance cannabis. There are people who are relatively casual users of heroin, cocaine, and they don't wind up in over their heads. I'm having trouble keeping my headset over my head. And there are some who they did have trouble with the substance. Maybe they had formal treatment and they don't use those substances, but they're, at least so far, comfortable with their values and risk tolerance using perhaps alcohol or cannabis. Some people call that California sober. And a lot of people have stopped on their own, similar to what Ann Fletcher describes or the Kelly survey describes. And that stopping may be temporary or it may be permanent. And some people stop without having a substance use disorder, or someone may have used it excessively and then stopped, like the individuals who might mature out of an alcohol issue. And there are individuals in our communities who remain abstinent temporarily or permanently from some substances, perhaps all substances, And they do it without an ongoing program. Program is a term often used to refer to 12-step program involvement, Alcoholics Anonymous, Narcotics Anonymous, and such. And they don't necessarily adopt the identity. They don't identify themselves as having a serious substance use disorder, or as alcoholic or addict. And they may be in what an outsider might consider recovery, but they don't identify themselves as that. Individual says, doesn't use alcohol. Oh, are you in recovery? No, I just don't drink alcohol. And it would be useful if we all got comfortable with that. Now, some people achieve their change from excessive use to modest or non-use of a substance by realigning their values. They may be committed to career, business, family, or a non-using partner. My bias as I worked in hospital residential programs was that there were a lot of people, probably most of the people I met had had treatment before. A lot of them did follow some sort of program for a while, and they got away from it and they picked up. So if I would be talking with someone who'd had treatment before, I'd be curious about that, looking to confirm my bias. Well, did you have treatment when you stopped? And a lot of people did not confirm that bias. They said, well, no, I started a business, I was raising a family, and it wasn't till after, my life changed, decades later, that I started to use again and got this trouble. So that's one possible pathway people take. Bill Miller, who on his way to helping establish motivational interviewing as an addiction psychologist, described what he called warm turkey. People don't immediately become abstinent, but they learn from experience that for them, efforts to control use were either futile or not worth the risk and inconvenience. I've encountered a number of people who perhaps thought of opioids as a nutrient they needed and then decided they were better off changing their diet. So shifting perspectives for providers or anyone in the community who's observing this. We used to talk about abuse and dependence. Now we talk about a spectrum of severity, and I'm putting emphasis on the milder end of that spectrum. Even in the diagnostic categories, we talk about substance use disorder, mild, moderate to severe. There are some people in the field that they'll say, well, I'm using substance use disorder, and that equates to addiction. And I'm saying, not the way that I think about it. And I encourage us all to think about the spectrum from no use through some or a lot to addictive use. Used to be one approach to treatment. Now there are multiple recovery options. I deliberately didn't say multiple treatment options because some people find their own path to recovery without passing through formal treatment. Clinicians used to feel obligated to break through denial and get people to admit to a label or category or diagnosis. Now, motivational interviewing has scientifically determined that that's toxic. It can be shaming and contribute to the problem. And now there's respect for what the patient, the individual, the person wants to call it, not so much saying, well, they have to admit this or they have to admit that. Old school abstinence was expected. And now I want to emphasize non-abstinence exists. As professionals, we want to acknowledge it exists and to neither condemn nor advocate non-abstinence. Medications in the past were not routine for substance use disorders. Now they're routinely offered in most treatment centers and doctors' offices for particularly opioid use disorder and alcohol use disorder. And thankfully, we're moving from the notion that if you just go to rehab, you'll be all better and we don't have to deal with it anymore, an acute care model to a chronic care model where we can involve people with ongoing healthcare assistance that will help keep problems at bay. So I'm saying variation is the norm. It's how things are. And person-centered healthcare, when we focus on the individual, we're accommodating variation. And there's a lot of person-centered healthcare already. And clinicians do approach healthcare in terms of the individual or the person's strengths and limitations, their distress and distress tolerance, their values, and their desired level of functioning. I would use my own experience with surgeons as an example. In sports, I'm probably more inclined to bump into people who are more sturdy than I am, and I have a wrinkled nasal septum. A couple of ENT doctors said, well, we could fix that. Does it bother you breathing? No. Does it bother you cosmetically? No. Then we don't need to fix it. Tailoring it to my point of view. Orthopedic problems, knee injuries or whatever. Orthopedists were very interested in whether professional sports were my livelihood. Not really. And if I was able to function the way I am, they didn't need to repair anything. Person-centered care, call it patient-centered care, which is the term used in a lot of research, or individualized care. There's lots of research to show it helps patient satisfaction, quality, better outcomes, reduces healthcare costs, and reduces disparities in healthcare. With the COVID pandemic, we've become much more aware of how healthcare resources are unequally distributed in populations. And if we're doing the best our healthcare technology and person can provide for every individual, then we're helping to correct some of those disparities. Some quick characteristics of person-centered care. It's collaborative. It makes sense to the person and the provider. It's consistent with the person's values and the person's risk tolerance. Come back to risk tolerance. Respects strengths and limitations. It encourages not only participation, but it matter-of-factly respects the individual's autonomy. And what we find, what people teach in motivational interviewing, what I found in my own professional work, the more I emphasize the individual's autonomy, the more responsibility they seem to take. If I say, you need to stop smoking, that doesn't necessarily result in action. If the individual says, based maybe on the context of our conversation, I need to stop smoking, that has a lot of weight, and they're more likely to follow through on that. And if I'm working with respect for the patient and not judging them, they don't need to get defensive about what they're doing. They can get thoughtful about what they're doing and not doing. So keeping the focus on the person. How can a person tell if they have a problem? Earlier, we described classic genre addiction as the relationship with the substance has displaced, eclipsed other values. This is a more subtle description. Substance use disorders feed the wrong relationships. A substance use disorder is repeated substance use that harms the individual and or people and things that person cares about. When I was describing my experience with vanilla extract, I said I stopped drinking in 1989. I was aware I liked it too much. I saw a danger, so I controlled the drinking. It was like weekends only or whatever. And there are people in classic genre recovery who'd say, well, if you have to control it, you got a problem, you better join with us. Well, I didn't go that far, but I mitigated the risk by not drinking. And the incident that tipped the balance, I had 2 drinks on a Saturday night in January, was going to be with family, especially my 2 children, taking down a Christmas tree the next day. And I woke up with a headache. I was one cranky dad, and I didn't like the impact on my family. I don't know whether that was a hangover or a headache from some other cause, yet it tipped the balance. Drinking threatened my more dearly held values, so I haven't bothered with it. Now, if somebody wants to get into this sort of reflection and weigh where they stand, we can invite them to reflect on their risk and vulnerability factors. Genetics and trauma. I got a lot of risk factors with genetics, not so much with trauma, but individuals who've had adverse childhood experiences, deprivation, discrimination, are more at risk for that relief from displeasure, negative reinforcement that can build to automatic behavior. Experiences and consequences so far, my own experiences with alcohol up until that point, I realized I liked it too much. So my values and attitude toward alcohol changed. It was no longer this symbol of the good life. It was more a threat. So it was easier to dispense with it. Protective factors. I have a fair amount of education, employment, stable living situation, so that those sort of would give me a better prognosis should I have needed treatment at any point. The protective factors and everything in this category on the slide fits with that recovery capital notion. The term recovery capital is a bit misleading because it exists before there might even be a substance use disorder, affects vulnerability and prognosis, as well as typically gets better when people transition into some form of recovery that makes sense for them. Environment, ease of access to substances, the stressors that come from the environment are dangers, and the attitudes of peers toward use or non-use are also strong influences on use and opening the door to the possible progression. So I'm saying the risks are there, and they may lead to a substance use disorder, they may lead to addiction, and substance use even without disorder. Those people who rarely touch anything at the bottom of that triangle, even once, can be dangerous and occasionally fatal. Some of the overdoses with opioids are naive users. They don't have any experience, and they use too much, and they're not rescued, or they're not, there's not help there in time. When we all became concerned about the spread of HIV, there was talk about safe sex. And then people looked at the language and thought, well, even intercourse with condoms or whatever carries some risk. So let's use the word safer sex. Somebody may have said the only safe sex is no sex. Well, there's a spectrum of risk. I cross the street outside this office, I'm taking a risk. I look both ways, maybe look both ways twice. So I'm trying to mitigate or reduce that risk. And there's risk. Some individuals with a lot of vulnerability, a nurse was talking yesterday about a friend who used heroin once and was off and running. Individuals describe the intense experience of pleasure from a first use of an opioid or cocaine, and they're off and running. Back on language, with harm reduction, people would talk about safe injection sites, and that language is changing to supervised injection sites, which is a way of describing it or identifying it that doesn't imply that there's no risk. So individuals who are trying to place themselves in this spectrum of use, non-use, and what to do about it, we can invite them to reflect on their own risk tolerance. How much risk are you willing to take and tolerate? And what is responsible use for you? Like crossing the street, risk is inherent in all aspects of life, including substance use. And I'm saying risk tolerance is a personal and individual matter that is subject to change. Responsible use or non-use is relative, individualized, and subject to change. Persons whose use compromises their values often adopt more stringent measures. That's what I did with alcohol. I went to abstinence. When I think about this, I also think about my own experience riding a motorcycle. I hadn't ridden for 35 years, bought a motorcycle a few years ago, did not put lots of miles on it, had enormous pleasure on country roads in Vermont. Wasn't riding enough to be competent and comfortable in traffic. Had a few experiences where I rushed into a rotary or came too fast on a yield sign, and my safety depended on other drivers. Didn't get honked at, but I realized my safety depended on other drivers, and I was inconveniencing people. I do not ride the motorcycle anymore. It's sold. I have pleasant memories, yet the discontinuation of that had to do with protecting my own safety. But as I've thought about it over several months, what really got to me was the effect I was having on other people. It was distasteful to me, didn't go with my values, and that made it all the more easy for me to move on from that activity. I don't know about you. I'm having difficulty adjusting to the prevalence of cannabis in our communities. And I don't think if I were the architect of laws and laws changes that I would have put it there. It's there, people use it, and they're comfortable with that risk. There are some people who won't take the risk of getting on a commercial airliner. That's a risk that I take. There are some people who won't take the risk of riding a motorcycle. That's a risk that I took that I'm not taking now. Well, cannabis involves some risk. I did some substance abuse education in the late 1960s in schools, and we didn't have much evidence. And the approach then was scare tactics. We didn't have much to scare people about cannabis in those days. Now there's been decades of research showing that there are some risks, and a lot of people are proceeding as if those risks don't exist. There's a college newspaper article from 1996 after I gave a talk to college students. I'd given one talk to college counselors on cannabis and was asked to give a version of that to students, which I did. Doctor details health risks of marijuana. The audience reacted passionately to much of what Kane said and engaged the doctor in an hour-long debate following his speech. I think of it as a conversation, not a debate, yet that's how it was represented here. Reporter who wrote this article quoted a sophomore who said, "Casual use in a responsible fashion does not have any serious repercussions." And I would say the repercussions are in it has to do with the risk tolerance of the individual. There are certain biological things that go on. During the body of this talk, I talked about the adverse effects of marijuana, cannabis on memory, especially immediate recall. Gave an example. You talk to someone who's smoked weed, and they're telling you about something in the gymnasium, and then all of a sudden they're telling you about something in the cafeteria, and it's as though they didn't remember the beginning of their own paragraph. No sooner were those words out of my mouth, hand went up at the back of the room. I said, yes. Student said, I'd like to say a couple things. And I said, sure, go ahead. And the person said, well, I smoke marijuana and I don't think it's that bad. And kid down front says, the person can't even remember the second thing they were going to say. So again, there's some biologic stuff going on that is real, and there's a lot of science there. And I don't get to dictate whether some teenager or 20-something person smokes marijuana. It would be good if they were aware of the risks and took those into account as they make their decisions in light of their own risk tolerance. So anyone who's been looking at this might decelerate their use, modify consumption, and take realistic precautions. That may not be realistic for people in the deep end of the pool, but for everybody else, that may be totally appropriate. Non-use may or may not be necessary. And I think healthcare providers can go too far in advocating non-use or relieving people of worry about use. Anyone who's deepening their positive interpersonal relationships, that's sort of the opposite of what happens with growing substance use disorder or addiction, and they're growing their own resilience, whether or not they've had trauma in the past, avoiding traumatic relationships, making them more, if they're in prevalent trauma, increasing trauma, that leaves them more vulnerable to the negative reinforcement of substance use. People who see themselves as having an issue, they may access mutual help, peer support, or not. They may need or want or accept professional treatment, counseling, therapy, or not. They may access medication or not. And any of these can change at any time. This menu, if you will, if we've internalized it, helps us to be more able to be person-centered rather than to impose our views on people about what they ought to do. Bill White again, saying that modern research has confirmed that some people with some of these problems can moderate use. And back to the Alan Marlatt statement, some people will moderate and go to abstinence, some will go to abstinence and go to moderate, and it can change based on consequences. A definition of recovery capital from William White and William Cloud, and I'm saying it matters both before and after substance use. So it's this mental and emotional and social assets that people have that can protect them from getting into deep water with a substance, and can help provide a positive prognosis if they do get into trouble. And it's something that gets better when they are in recovery because they're looking to grow and deepen relationships and advance according to their own values. Famous American, I'll say poet, composer, Bob Dylan, I think understands this recovery capital when he says, when you ain't got nothing, you got nothing to lose. Which brings me back to the South Bronx and the disadvantaged and the people who have a lot of socioeconomic impediments to moving ahead and more, I'll say, ongoing trauma or insults to seek relief from. General principle, each person's personal responsibility and risk tolerance are relevant at all levels of substance use. And my hope is that we'll move in our communities to an awareness of substances that are going to be available, and some are increasingly legal. And that can be okay if people are looking out for themselves as they go along. This slide has sort of analogy between climbing a mountain and using a substance. Someone who's climbing a mountain should pay attention to the weather, the terrain, their own experience. Do they know what they're doing on a mountain? How do they feel physically and mentally that day? Are they up to the task? Are they dressed for it? Do they have the equipment they need? Food, water? And is there help if they need it? Should they be injured or develop hypothermia? Before using a potentially dangerous substance, what is the substance? People using a street drug don't really know what they're getting. What's the social and legal setting where they're going to use it? What's their experience? Do they know what they're doing? Pun intended. Do they know what the substance is? But also, do they know how they're going about it and what the dosing would be and the risks would be? How do they feel physically and mentally today? Are they seeking relief? Are they asking for negative reinforcement? Are they asking for relief that could set them up for continued problems? And is there help if they need it? Do they have a designated driver? Is there naloxone if they're at risk for overdose? Is there someone there who knows where to use it? Is there someone there to talk them down from a bad trip? In the trend toward the use of psychedelic substances for therapy, they're often used in very tiny doses with someone there to help the individual if there's an adverse effect. So I think we need to retool how we think of recovery to accommodate this whole spectrum that we've been acknowledging here. There's some wonderful discussions of recovery in Sampson's working definition of recovery. William White's papers has a lot. There was an institute at the Betty Ford Center in 2007 that defined recovery as a voluntarily maintained lifestyle characterized by sobriety, personal health, and citizenship. And where interpreters of that definition have had trouble is on the sobriety part. Is it absolute, old style, generic abstinence from everything, or is there a place for nicotine if people still smoke? Is there a place for the people who might have non-problematic use of alcohol or cannabis or some other substance? As I've tried to reconcile my maybe dated thinking with what I experience in the outpatient community I work with now, I've tried to think of what the essentials are. And I've come down to this. I think of recovery as person-centered. It's characterized by humility, honesty, and responsibility. Now, even the old school stuff, 12-step programs, did a lot to promote humility. Now, the founders of Alcoholics Anonymous, a stockbroker and a physician, may have needed to be taken down a peg or two in their own estimation to be more human and able to take better care of themselves. People who have not had advantages or enough respect may need to be sort of boosted by our regard and our respect for them. And my pitch here is to be flexible about the idea of abstinence. I've been forced to grow in that direction by what is going on in the community around me. And with non-judgment, sometimes people will, on their own natural tendencies, on their own steam, move to a more careful use. I like William Glasser's description of responsibility, the ability to fulfill one's needs and to do so in a way that does not deprive others of the ability to fulfill their needs. So if someone is maintaining their own substance, the expenses of their own substance use by dealing, that's not okay in an ethical framework or a responsibility framework. My discontinuation of riding a motorcycle had this sort of framework of not wanting to deprive others of their ability to travel safely. I've kind of alluded to this, but I want to emphasize this. There are possible unintended consequences to the kind of non-disordered use of substances. When I'm talking with individuals who are coming from the deep end of the pool, they have a relationship with a substance and they talk about the cocaine or the alcohol or the heroin, and sometimes their face lights up. There's sort of this smile, and when I observe that they're smiling, talking about it, they sometimes gain insight into how attached they are to it. There's sort of a romance with the substance. Sometimes when individuals with a high level of recovery capital are using, it's within their risk tolerance to use cannabis, let's say. And when they talk about it, their face lights up a bit. And that's okay if they're with, I don't know, birds of the same feather. However, if they're with someone who's has more risk factors for problematic use, or is looking to establish a recovery from a substance use disorder, that positive energy in the direction of the substance, consciously or unconsciously, may promote use by others. When I'm talking with patients about my own history of cigarette use, I resist naming the brands, because to me that had a cool factor when I was doing it in my mind, and I don't want to romance those substances in the eyes of people that I'm talking with. I want to wrap things up talking about categorization and ways of thinking about substance use disorders in the community and causation. So the way we categorize these things, if it's a choice, if we think of it as a sin or a choice, that's pretty destructive. Lots of people have thought of addiction, alcohol addiction, as a disease. Jelinek's famous for it. National Institute on Drug Abuse uses the term chronic relapsing brain disease. The American Society of Addiction Medicine talks about a chronic medical disease. And in our diagnostic nomenclature, in the Diagnostic and Statistical Manual for Abuse and Dependence, now we talk about substance use disorder, mild, moderate to severe in DSM-5. There are individuals in the field or recovering from substance use disorders who are highly attached to some of these categories. There are others who debate it. Stanton Peele would call addiction a personal self-defeating habit. Mark Lewis, a recurrent desire for a single goal. In fact, the controversy is heightened by Lewis's book. The title of the book is The Biology of Desire, which deals with some of the same neurobiologic stuff that I talk about and others talk about. But his subtitle is Why Addiction is Not a Disease. Maya Salovitz talks about substance use disorder, severe substance use disorder, as a learned relationship. I want to emphasize that the debate about these things holds us back. When people debate, is addiction a disease, the question is flawed. A more relevant question is, can addiction be classified a disease? Back to what we said before about labels and classification. It's a classification. It's not a thing. Can addiction be classified a disease? Yes, it has been for decades, and that has advantages. It accesses, medical science and research funding and insurance benefits for people affected. And at least for some people, it reduces the judgment of themselves and by others. These alternative descriptions that exist are also useful for some, and it's the key to recovery for some, and that's valuable too. The backstory of diseases is relevant, and this is why a rationale why the debate is unnecessary. Diseases are categories for people with biologically similar health problems. There's a branch of medical science, nosology, that deals with the grouping and regrouping of people in disease categories. These categories change based on what we know about causal mechanisms and responses to treatment. And they're simply categories, they're concepts, they're not things. They don't exist on their own. They only are convenient categories or labels for groups of people that have similar characteristics. And it's the specifics that grant the actual existence. Famous French physician in the 19th century said, there are no diseases, there are only sick people, which captures the reality of this. And to regard a concept as a concrete thing. It's sort of a logical or a epistemological fallacy of reification. That's treating a concept as a thing. The person who wants to buy a chair can't sit on the concept of chair. They need to have a particular example of that to sit on. And again, people defending addiction as a disease, people attacking addiction as a disease, they seem to not have this grasp of what disease is. Now, nosology is sort of allied with concern about health issues in groups, the science of epidemiology. In 1980 or so, epidemiology was a neglected science. People weren't interested in it. But now it's 2022. We're in the midst of the COVID pandemic, or maybe the end of it, let's hope. Everyone wants to be an epidemiologist. So we may be more ready to understand this stuff. So labeling addiction as a disease is still controversial. I think it's sort of unnecessary or pointless, but it can be reasonably classified as a disease. And there are other ways of describing addiction without using the disease that are valid and useful. Maya Salavitz's book, Unbroken Brain, individuals have found their path to recovery using her terminology and her ways of thinking about it. Just to emphasize the feeling about this, going back to the Red Sox and the Yankees caps, if you will, and the adversarial energy, the colliding speech balloons. In 2016, I posted a blog on the website of the National Council on Alcoholism and Drug Dependence, saying some of the stuff that's on this slide. And I made the point that if people were talking about professional wrestlers, the wrestlers are who they are, and they do what they do, and that's sort of factual. How they're classified is kind of arbitrary. Would it make sense to argue whether wrestlers are athletes or entertainers? And I think that's like what people have been doing. I thought I was doing the field a service by putting this out there, yet the response, some people said thank you, but at least a couple of people came back and sort of attacked me as a heretic because it seemed like I was taking sides on the argument that addiction is not a disease. It's classified a disease. That's okay, that works. We don't need to argue about it. So rather than waste time and energy trying to put labels on people who have substance use disorders, we need to find a way to work with them, and strong help for motivational interviewing. There's a automatic response that we humans have if we think someone's on a wrong path. It's like seeing a toddler headed toward an outlet with a piece of metal. We jump on it. That can raise the defensiveness of somebody. If like I said before, if I tell someone you need to stop smoking, that has them primed to say all the reasons why that's not such a good idea. If we overreact to things, we compromise their autonomy and steer them or make them more likely to move in a defensive direction. Motivational interviewing is described as, it's like dancing, not wrestling. So we want to not increase somebody's tension and defensiveness. Stephen Rolnick has advocated instead that we be a compassionate guide, not drag people into change. What compassionate guides do is they come alongside them and help them get the best out of themselves. So our overall objectives is that we want to promote healthy behavior, and listening is key to that, and absorbing the details of someone, because that's where the engagement and the solutions they arise from the person we're centering on, not so much from what our preconceptions are. Resist cues to make the encounter about you. We can share our humanity, not necessarily our biases, and not be defensive. One of the clinical experiences in my life I wish I could replay. It was a lost opportunity. an individual in treatment said, well, you've never been in heroin withdrawal. I felt I needed to come back. I came back and I said very coolly, you don't know that. I was proud of that comeback for years until I took into account that person signed out of the hospital either later that day or the next day. Lose-lose outcome. I wish I'd just made a reflective statement that kept the focus on him. Something like, you believe that if you make me feel guilty enough for what you're going through or convince me I don't know what I'm doing, then I'll prescribe methadone for you right now. That would have put it back on him. Be very interesting how that might have unfolded if I hadn't let it become about me. So we want to know what's going on with the individual right now and how to help. Doesn't mean we can't think about other things. Somebody comes in for a sore throat. If they describe rectal bleeding, in medicine, we have to respond to both problems to keep the patient and the patient's priorities in our radar. Resist urging changes the patient is not prepared or equipped to make. An individual is living with someone who's actively using a substance, yet their housing and financial support and health insurance all depends on that relationship. To just suddenly say, well, you got to do something else, it doesn't make a whole lot of sense. So that if we're patient-focused then and patient-centered, then we can be individualized, and that helps us to be more effective. Zulman and others wrote about practices to foster presence and connection in relationships, and preparing, take a moment to focus on the person before encountering them. If I read my last note before I sit down with the patient, I'm much more centered on that patient. Listen intently, show respect and intention, find common ground and work out an agenda together. Connect with the patient's story, their life circumstances, affirm things, and explore emotional cues, and name and validate the patient's emotions. If we're a healthcare provider, we expect ourselves to provide a certain amount of technical services with medication, withdrawal management, contingency management, having little rewards for positive behaviors as part of treatment is an evidence-based treatment. As a field or an industry, we're looking to find more ways to harness that productivity. But besides the technical, there's the interpersonal. Non-judgment protects everyone's dignity. Using person-first language and not be blaming. Part of that patient education that I found is necessary is letting people know that there's more to who they are and more to why they do the things they do than what meets their own mind, so that they can understand that disconnect between intention and action. And Robert Ornstein, we're worse off than Freud thought, because many actions proceed without our knowing anything about them. The unconscious and the role of emotion is a bigger thing in our behavior than a lot of people realize. And there's even a shift in mental health from focusing on cognition to focusing on emotion or affect as people look to resolve certain problems. Distribution of responsibility. I like what Mansell Patterson wrote several decades ago now, but emphasizing that human behavior is both chosen and determined, and that the determined part is the disconnect between intention and action. Blame and punishment don't help. Let's not do that. Each person and each community must share responsibility and be responsive to one another. So that in this atmosphere with no blame, in several ways, everyone in a community is responsible for the alcohol and other drug problems that exist there. Prevention may be more about what the community does. Treatment may be more about what professionals do, both technically and interpersonally. And recovery, though, is person-centered. It's about what the individual does. Often in treatment circles, well, so-and-so isn't doing well, they need to go to treatment, meaning they need to go to residential treatment or rehab. That may help, but it also depends on what the individual does when they're there in terms of growing insight, responsibility, deepening connections, and humility, honesty, and responsibility while they're there. This whole situation is a bigger picture than the individual's brain. Preventive medicine or epidemiologic perspective, disease may be defined as a failure of the adaptive mechanisms of an organism resulting in a disturbance of structure or function. So, and function in relationships, that persistent use despite adverse consequences, is sort of a short way of describing addiction. Substance use disorders it's not the sort of total involvement in that relationship, it's the compromise in other areas of values. But it's possible to conceive of disease manifestations and causes at any level from the molecular to the social. And there's, in medical science, there's often an emphasis on the molecular or the cellular or the organ level, and the social doesn't often get into the mix. Yet there's this big area of understanding and research on the social determinants of health. It has been a convention for clinicians to say, well, we don't deal with like society, we deal with this other more scientific organic stuff. Yet the Preventive Services Task Force is now encouraging care providers to screen for the social determinants of health and have resources to refer people to deal with income issues and food issues and that sort of thing. This list of social determinants I took from I think a SAMHSA website, but I added transportation and childcare and media into the list just to make it more inclusive and present a more comprehensive picture of the many factors, including social inclusion. This has non-discrimination. I would say discrimination, poverty, a huge housing, huge factors contributing to health or ill health. And again, rather than focusing on one segment, to think ecologically, the whole picture. The environment host in this diagram represents the potentially susceptible person to a disease or a health problem. Agent could be an infectious agent like the coronavirus or the parasite that causes malaria, or a chemical agent like alcohol or cocaine or asbestos. And thinking comprehensively about these things and these two-dimensional arrows, it's all interacting all the time. And people who want to sort out what to do about this, instead of thinking of immediate cause and effect, they might draw a web of causation. In the book Inner City Alcoholism, I drew a web of causation, thinking about the emergence of alcohol dependence or alcohol use disorders in the South Bronx. But here in the middle of the diagram is social gatherings. That could be a bottle gang on the street corner in the South Bronx. It could also be a cocktail party in a country club in the suburbs. The availability of substances, alcohol, affects use and the possible progression of things. People who wanted to reduce venereal disease in adolescence increased the tax on alcohol, which reduced use because adolescents are price sensitive when it comes to acquiring alcohol. And they reduced gonorrhea by increasing the price of alcohol, which reduced its availability. Where I was working in a storefront alcoholism treatment unit in the South Bronx, alcohol was very available. Within a block, there were 6 places to purchase alcohol. We closed the storefront we were in, moved to bigger space, and shortly after we moved out, an after-hours club moved in. So now there were 7 within that block. The distribution of alcohol outlets in the South Bronx that's not about the drinker's brain. That's about a whole socio-political, structural complex that I can't describe the dynamics of, and I know it's a risk factor for people living there. So there are lots of conflicts of interest that color these diagrams. The diagram, though, can help understand causality and isolate places to intervene. Malaria caused by a parasite transmitted by mosquitoes. Well, there are medicines that people take that make that parasite less virulent if it gets in your body. That can be good. Why let the mosquito get to your body? So put netting over your bed at night. That can help. But then people look at the life cycle of them, not just the parasite, but the mosquito. Well, why don't we drain the swamp so we'll have fewer mosquitoes and have less malaria? And that's the sort of open-minded, problem-solving approach that we need if we're going to reduce substance use disorders in our communities. If we have non-judgment, we're protecting everyone's dignity. We're less likely to have people experiencing adverse childhood experiences. And it makes it easier for people to ask for help if they're not going to, if they have a problem, because they're not fearful of being judged. Reducing financial and food insecurity, discrimination, violence reduces demand. Reducing substance availability, like I was just describing, reduces supply, which reduces use. Increased resources for treatment. There has been growth of medication for opioid use disorders with methadone programs and prescribers providing buprenorphine. There's way more than we had 10 or 15 years ago. I'm not sure that we have met all the demand yet. And increased resources for healthy living, that's a community issue. Famous research in Iceland where there was concern about binge alcohol consumption in adolescents. And they did multiple things, including reducing the availability, the access to alcohol among adolescents, and also increasing adolescent adult interaction, both within families and outside of families. And they also enriched the after school programming for adolescents so that there'd be more attractive options that they would want to invest their time in rather than hang out and perhaps drink. Since I know the early 70s, I've been quoting the saying that the treatment of addiction is people. It may also be the prevention of addiction. So people matter. We want our communities to be competent. Before the notion of recovery capital was around, I was well aware, like in 1980 or so, that there was a body of research showing that the more strengths people had in terms of education, financial security, housing, social supports, they had, if they developed a problem, their prognosis for getting better was better. That's if you ain't got nothing, you've got nothing to lose. If you have got something, you've got more to lose, and that's motivating. If we think not just of individual social competence, but competent communities, then healthcare providers and everyone else respect and protect everyone's dignity. There's a culture of non-judgment. And everyone, including healthcare providers, are called to do what they can do to address these social determinants of health: poverty, discrimination, hunger, unemployment, and violence. And I'm saying if we're going to really get substance use disorders and all the harm and tragedy that go with them under control, as individuals in our communities, it's important for us to rise to these challenges. We can understand these issues in terms of relationships, and if we generate mindfulness, awareness of ourselves, appreciation of ourselves in the moment and where we're at mentally and emotionally, and where the people we're at mentally and emotionally, a process sometimes called mentalization. If we're aware of ourselves in that moment without judgment, we're much more effective. And by mindfulness practices, we can sort of, as trainers will say, build the muscle of equanimity, get better at not judging ourselves and others, and therefore being more effective in those relationships. Through practices of meditation, maybe just being outside or being creative with art, music, martial arts, sports, yoga can contribute to mindfulness. If we do it for ourselves, we're healthier in our relationships with others and helps them to get better. If they adopt these practices themselves, then that becomes something that's an ongoing benefit for them. At the University of Rochester, Ron Epstein, Mark Krasner have mindful practice programs for healthcare professionals so that you can go on a retreat and immerse yourself in this stuff and emerge, I believe, better off. So finally, some takeaways on talking. We want to individualize. People are real, labels are not. We want to connect with people and empower them to make healthy changes. Mindfulness helps us and them. Respecting the values and risk tolerance of those we serve is our mission. And it can be potentially harmful to disagree if people find it within their risk tolerance to use substances, and potentially harmful to agree. So we don't want to take sides on the abstinence harm reduction thing. We want to support safer practices and not be casual about risks. Finally, I want to sort of leave you with this to think about, yet I want to close by commenting that a lot of the patients that I have served in and out of the South Bronx use a lot of four-letter words. I would like to leave you with some of my favorite four-letter words. Thank you very much.